The time is now noon, so I will get started. I'm sure more people will join as we do get started here today. But thank you to those who have introduced yourselves in the chat. While I'm going over our introduction, please feel free to introduce yourself, your credentials, your practice, and your county in the chat so we have an idea of who is in the audience today. And if you're not sure where that chat is, it's bottom right-hand corner of your WebEx. But my name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service. I'll get a little more into what we do at MAX, but before that, I do just want to go over the credit process for today's webinar. We are offering CMEs and CEUs, and in order to be eligible for full credit for today, you do need to be on for at least 45 minutes of today's webinar. That will be 45 minutes of the content, so please just stay on for the entire time. And you will be able to access the evaluation survey on the Max Oasis portal, which you signed up for the registration through. If you have not attended any of our webinars since about February, this is a new part of our training process, and we have implemented it to streamline the certificate process for you. So once you log into that portal and click on today's webinar, I will mark your attendance by the end of the day today or by the end of the day tomorrow, depending on if you call in or you join late today. And basically, once your attendance is marked, you'll receive an email, and then you will have access to the 9-question evaluation survey. Once you complete the evaluation survey, you'll be able to download your certificate directly in the portal. One important thing to look out for is you have to claim the certificate that you would like and waive the certificate you would not like. So if you want CEUs, you claim CEUs, but then you have to waive the CME certificate. If you're not sure which certificate applies to you, you will have access to claim both, so feel free to do that as well. But please make sure, once again, you attend today's full webinar and you fill out that evaluation survey, and you have access to the portal. If for whatever reason you don't have access to the portal, please email me directly and I'm happy to set that up for you. But you will also receive a copy of today's slides by the end of the day today, and additional Max resources via email. So please look out for that. We are recording today's webinar and it will be up on the Max for Moms website within 1 business week. And you can access all of our previous webinars there as well. So now I'll give an overview of what we do here at Max for Moms. So Max for Moms is a part of the Maryland Addiction Consultation Service. The MOMS portion stands for maternal opioid misuse. And Max is a grant-funded program by the state, so all of our services are completely free. And they include a warm line for all of your clinical questions. We call it a warm line because it's open 9 a.m. to 5 p.m. Monday through Friday. And don't call us with urgent needs, but if you do have clinical questions about specific cases, when you call our warm line, you'll be connected with a behavioral health consultant who will screen what you're looking for, get a little more background information on the patient, and get a little more background information on you as a provider. And then they will connect you with the appropriate consultant who may have a specialty in the case that you're looking at or has more specific expertise on your needs. All that information when you call us should be de-identified. And we also offer other services, including education like today's webinar, which take place during, usually during the lunch break, 12 to 1 to accommodate busy schedules. We also offer more specialized education. So if you would like us to come into your practice and present on a specific didactic topic or just general best practices in treating opioid use disorder, we are happy to do that as well. That kind of connects to our technical assistance piece, which is individualized capacity building to practices implementing or expanding office-based substance use services. And while this may look like trainings, it also could look like helping you find an office space if you're opening a new practice, to even helping you establish protocols and guidelines, as well as just materials for everyone in the office so everyone is on the same page about treating substance use disorders. Kind of connected to the training piece that we offer are our ECHO clinics. And these clinics meet once a month, and they are collaborative medical education through didactic presentations and case-based learning. What that means is someone from the medical community will present from their own caseload. They will pose questions to the group and then receive feedback on how to move forward in treating that case. And that is paired with a didactic presentation by someone on our consultant panel. We do have a Max for Moms specific echo clinic that is the second Tuesday, 8 a.m. to 9 a.m. of every month, and I'll put that registration information into the chat. So the next one is going to be next Tuesday, and I'll include the information about what that didactic will be about. And then more specifically, Max for Moms supports maternal health providers in addressing the needs of their pregnant and postpartum patients with substance use disorders, and today's webinar is a part of Max for Moms. Also included in Max for Moms is Dr. Welsh, who is the director, and I will give a brief introduction. So Dr. Welsh is the medical director of the UMMC Substance Abuse Consultation Service. So basically Max, but specifically for the UMMC campus. He's also the medical director of the UMMC Outpatient Addiction Treatment Services and the medical director of the Maryland Center for Excellence on Gambling. His main area of clinical work is in the area of substance use disorders. He works in various in and outpatient settings, as well as via telemedicine, including methadone and buprenorphine maintenance, and he has an interest in substance use in pregnancy and the medical complications of addiction. He also works for the Baltimore City Department of Health and the State Department of Health on expansion of treatment for opioid use disorders, needle exchange, opioid overdose prevention, and other harm reduction initiatives. Along with the Institute of Human Virology, he also works in Kenya to increase treatment of heroin use disorder, and he is involved with the training of healthcare professionals in various areas, in various addiction-related areas. Dr. Welsh, thank you so much for presenting today, and I will turn it over to you now.
Okay. Are you seeing a normal PowerPoint?
Yeah.
Okay. All right, well, thanks. I have to remember to give Bridget a shorter introduction. It's a little much, but all right, well, then, welcome everyone. So yeah, it looks like a real wide variety of clinicians here. So this might be real basic for some and hopefully new for many. We're just going to really kind of do an overview of motivational interviewing. I mean, the focus of Max for Moms is on perinatal, but really it isn't fundamentally different. So again, it's going to be really kind of just basic motivational interviewing. So just a little bit of history of motivational interviewing, because we talk a lot about this, but the beginnings of it really go back, and you can look at things in ancient history, but really in the present day, the beginnings go back to the 1940s. And back then there was a psychologist, Abraham Maslow, who started a movement called humanistic psychology. He talked a lot about self-actualization being an important thing. The 1950s, Carl Rogers, he started something he called person-centered therapy. And he came up with this term of unconditional positive regard, which is something that we'll talk more about, but really kind of just talking with people non-judgmentally. And you have to remember, in the mid 1900s, there was a lot of back then psychoanalysis was really the dominant force in psychiatry. So these were some of the early guys who were kind of going against psychoanalysis and that type of of psychology. So whoops. And then really what became what we think of as motivational interviewing started in the 1980s. And 1983 is when Bill Miller, who we'll talk more about, one of the real founders of motivational interviewing, wrote an article about this, the beginnings of this in a psychology journal. And then by 1991, Miller and Rolnick came out with the first book called Motivational Interviewing. And that's really what, when people talk about it, they're really mostly referring to what those two guys started in 1991. throughout the 90s, 2000s, where a lot of different spin-offs we'll talk a little bit about. In 2002, they came out with the second edition of their book, and then in 2013, the third edition. And it's really interesting, and people who are interested in this, I really recommend. I'll have it. I'll show you at the end the actual book, but it's actually very interesting that they have really changed a lot of what they talk about, or just the way that they kind of frame it between each version of the book. I mean, it's fundamentally the same thing, but it really they really have kind of changed, and it's very, it's an easy read. It's not, hard science, or so I recommend people are interested. And like I said, at the end, I'll show you the book. So there are a lot of things that over the last couple decades people have kind of based on motivational interviewing, but it's really not. And so it's important, like if you're reading a study, to understand were they doing kind of true motivational interviewing, or were they kind of doing something based on motivational interviewing? But the last couple decades, real, SBIRT, I'm sure most people have heard about, but the BI, the brief intervention in SBIRT, is based on motivational interviewing, but it's really not the same. It's not equivalent. The brief negotiation interviews, some other places call that the BI, motivationally enhanced therapy. So a lot of different things within medicine, but it's really also being applied now in, outside of medicine, in, sports coaching, classroom teaching, parenting. A lot of other places have really adopted the kind of backbone of motivational interviewing. Within the kind of the perinatal pregnancy world, we think about it mostly with substances, alcohol. There's actually, there have been studies looking even at preconceptional counseling of, women to, reduce or stop drinking during a period when they're not pregnant yet, but during which, if they were drinking and didn't know they were pregnant, it could harm the baby. Tobacco, obviously with the patient, but also especially after delivery with secondhand smoke, and doing MI with the significant others who might be in the household. Drugs, you know, obviously illicit drugs, but even licit, and cannabis now, and what, less than a month, it's going to be, technically legal in Maryland. And how do we, counsel around that? Caffeine, a lot of people have trouble giving that up when they get pregnant, so that can be used. But it's also just to remember that it's really focused on any behavior. And so, within this arena, sexually transmitted infection risk behaviors, contraception, just other kind of lifestyle things important during pregnancy, intimate partner violence, and again, any other kind of behaviorally related things. It's important to remember that the same basic, mechanisms are going to be used for addressing them as with substances. All right, so just some real basics of the definitions. And so these are right from the Miller and Rolnick, the third edition of their book. And they kind of have three levels of definitions that kind of sort of build on each other. But they all have kind of a lot of the same basic ideas in them. But the first one there, big focus of this is it's collaborative, it's conversational, and really the idea is that you're helping the person to try and strengthen their own motivation for change. The second one, trying to address ambivalence, that we'll talk more about, which is common in all behavior change. And then the third one there is kind of more inclusive and collaborative, goal oriented. So again, part of this even goes against kind of, like the psychoanalytic kind of, not very focused and goal oriented type of therapy. Um, we'll talk more about this focus on the language of change. This has been a big change for Miller and Rolnick in the third edition of their book. A lot more focus on the language of change. But again, highlighting that it's really trying to strengthen the person's motivation and commitment for change. So just some kind of basic assumptions, and I'm, guessing most of the people on this call, this is, kind of speaking to the choir, but it's just important that, one of the assumptions is that we think people can change, or else it's not even worth doing this. And then again, dating back to those psychologists kind of in the middle of the last century, a lot of the, kind of underlying this is that in general, when people change, they tend to change in positive ways. Not always, but again, that kind of goes along with the assumptions of why we do this. Another assumption is that most people are ambivalent about change and just try and think of things you may have tried to change in your own life. No matter how much it makes sense to make the change, when you've been doing something for a while, it's hard and it becomes part of your life. And so that leads to ambivalence when you try to change it. Also looking at motivation as not really kind of a trait of the person, which is often what we do, but really a state of the person being ready to make a change. Real important to look at specific, because a lot of people are like, well, the person doesn't want to stop using substances. You have to look at, do they want to address each substance specifically? And it's important to, realize just based on what's going on in someone's life, their readiness for change can fluctuate significantly. And then the bottom there is, really, and it's a lot of times in the healthcare profession, we kind of feel like we can influence people and make them change more. Like we spend time studying this stuff and they should just listen to us. And again, if you just think of things you've tried to change yourself, it can certainly help to have that background and expertise, but really all we can do is help someone else get to a point where they want to change. And just the Grinch is my favorite example of being able to change. So kind of a part of this is what people call the stages of change, or when it came out called the trans theoretical model. And some people argue, well, this isn't really how people change, but I think most people agree it's a nice at least model for thinking about behavior change. Um, I'm guessing most people are familiar, but if not, that, people that aren't even thinking about a problem, thinking about it, but not ready to act on it, preparation when you're preparing to make a change, action when you're making the change, and then maintenance is kind of once you've made a change, how you keep the benefits from that change going. Um, and just, the different ways of looking at it, but for most people, it's not a linear thing. They go up and down. Again, things in your life change motivation. So just important to remember that that's a very fluid process. It's also important, we'll talk more about this, but a lot of people are willing, they recognize they have a problem. They are even willing to do something about it, but they don't think they are able. They don't think that they possess what they need to make the change. Sometimes they've tried before, a lot of times people who've tried to stop smoking, many people have many, many attempts. And so if you've tried and not been very successful, then that each time kind of lowers your confidence that this is something you can do. So you want to be thinking of both, the person's willingness to change and their ability, and kind of those together lead to their readiness, as you're working with them. So just a little bit of why people don't tend to change. So part of it is that they're not convinced that there's a problem or that they need to change it. So they're just not motivated. They're not committed to making the change, so they're just at that time at least unwilling. And then, like I said, that third thing is they just don't think they have the ability to make the change. So they just don't think they're able to do it. So how do we help people to get where they can make a change? You want to help them become interested and concerned about the need for a change. Um, they need to become convinced that it's going to be in their best interest, that there's going to be more of a benefit than the cost. Sometimes organizing a plan of action that they're committed to implementing that we can really help a lot with. And then finally, that they actually take the actions necessary. So I mentioned before that ambivalence is a big part of change. And for a long time, I think people, have a hard time understanding when, you're injecting drugs and have multiple negative consequences from it. How can you be ambivalent about changing that behavior? But again, it happens with most behaviors, and it happens with most people that, once you've been doing something for a long time, there's just going to be ambivalence about changing that behavior. So it's really important to just kind of accept that and realize that's a lot of what your work with the patient is going to be. It's addressing that, not looking at it as though it's a pathological thing, which is, I think, for a long time in the addiction world, how we looked at people who were ambivalent about giving up their substance use. It's also important to recognize, and again, it's with many behaviors, but specifically with substance use, that some of the ambivalence comes from just kind of the timing of things. So if the positive effects of continuing to use are pretty immediate and predictable, so helping with withdrawal, helping kind of the numbing feeling you get, the positive effects of stopping substance use are often much more delayed, and they may be much more subtle than the positive effects somebody gets from immediate use. And kind of looking at the inverse, the negative effects of continuing to use often are very delayed. I mean, sometimes they may be, if somebody overdoses, that's obviously very immediate, but many of the effects, people can use, people talk about being functional but a lot of times the negative effects can be very delayed and less predictable, whereas the negative effects of stopping using, like withdrawal and other things like that, can be more acute and predictable. So a lot of this kind of, skews things toward continuing to use actually kind of being the easier thing to do. So again, part of that ambivalence. Another term we talk a lot about in this is resistance, which is again something that we've often thought of as, kind of a trait of the person. But again, really in motivational interviewing, you're thinking of this as a normal part of change, kind of along with ambivalence, and also looking at that a lot of resistance has to do with the dyad of the people involved. So it might be the patient and significant other, but when they're interacting with you, some of the resistance could be coming from your part, your biases about the behavior that the person's engaging in. It's a bigger issue, I think, when we're talking about pregnancy. Some people really struggle with, how could somebody continue to drink or use or whatever while they're pregnant. And so it's important to recognize that resistance isn't just from the patient, that some of it has to do with the interaction between you. So there are a lot of little kind of cute mnemonics and things in motivational interviewing. So, I'm going to go through a lot of these, and some of them, the different people find that different ones kind of help this stuff stick with them. So some people talk about the rah, 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 some of the goals of motivational interviewing. So helping the patient, reduce the desirability of the problem behavior, address ambivalence, recognizing the cost of the problem behavior, addressing barriers to change, recognizing the benefits of change, and achieving a sense of self-efficacy. So again, a lot of things that we've already talked about. The current version, the third edition of the motivational interviewing book, talks about the spirit of motivational interviewing. So these things are really important kind of fundamentally. It's really now kind of when we just teach clinical work and how to work with patients, it's really kind of fundamental to all of that. But again, things have not always been that way. So, but again, it's very much this working in partnership and collaboration with the patient and recognizing that, the history that the patient has with this behavior does give them some expertise in the area. Acceptance, so absolute worth, autonomy, accurate empathy, and affirmation. All these things kind of go back to that Carl Rogers, that unconditional positive regard of trying to work with the patient, accepting them and their behavior for what it is, working compassionately, which should be obvious. And then the last one there, the evocation of things rather than imparting. So certainly, you want to use what your knowledge of being a professional in this field. You're going to talk to the patient about things, but not assuming that just by telling them that that's going to change behavior. So you're working to trying to evoke from them the desire to change. The processes that they talk about in motivational interviewing, so engaging the patient, helping focus the discussion on the problematic areas. A lot of it focused on this evoking, so getting them to talk about rather than you just telling about. And then the last part there is the planning, the helping. Again, people may have tried to stop before, so a lot of times people need help with the kind of nuts and bolts planning of how to make a change. Another little mnemonic they have is the principles of motivational interviewing. They used to call it READS. So rolling with resistance, expressing empathy, avoiding argumentation, developing discrepancy, and supporting self-efficacy. We'll talk about these. The last version, third edition of their book, they actually got rid of this avoiding argumentation. And I don't think, they're not saying you should argue with patients, but I think getting a little bit away from that. But again, this idea of a lot of times when you're working with people that seem to be caught in a cycle of very destructive behaviors, sometimes this is kind of how you feel that just how can you continue to do this? So really just trying to avoid that. So a big part of motivational interviewing is this idea of rolling with resistance and not getting in arguments with the patients, taking what they're talking about and kind of going with it. Very kind of Zen Eastern philosophies, but this is a little diagram that somebody came up with. Just, a lot of times patients are going to come in with a lot of different issues, and they want to talk about that they're having a lot of sadness and emotional problems. You're pretty sure that a lot of this is related to their substance use and other issues. So they want to talk about that. You're trying to talk about the substance use. They want to talk more about the sadness. And if you don't kind of do that rolling with resistance and letting go, you can just keep going around in this circle. So the idea is that you kind of find something within what they're initially ready to talk about and go with that. And then, if they're related, they're gonna end up kind of tying together anyway. So again, this idea of working with the patient where they are and not trying to impose on them your agenda. Another little mnemonic that people use around some of the principles is the rule. So one of them is the resisting the writing reflex. So that's again this writing reflex, this idea of you as the trained professional kind of know what would be best and trying to jumping in and trying to force on the patient, how to kind of correct what's wrong in their life. Understanding the patient's motivation, again, it seems like self-evident, but stopping and thinking, trying to use real empathy and understand where they're coming from. listening with empathy. And then that last one, again, empowering the patient. And lots of little mnemonics. So another one, and again, this isn't just motivational interviewing. It's really how we should be interacting with all patients. But certainly this ORS mnemonic of using open-ended questions, affirmations, reflective listening, and summarizing. So we'll go through all of them. So yeah, I'm hoping most people are aware, but just kind of reminder of open-ended questions as opposed to close-ended, where somebody just will answer yes or no. Using open-ended really helps engage the patient more, and allows you to kind of see different areas that you might be able to pick up on to help kind of guide the discussion. So just some examples of open-ended questions. What concerns you about this? Tell me a little bit more about how does your substance use affect your relationship? Why would you want to make this change? Again, so just thinking, and as you kind of practice this, you'll notice, like as you're getting ready to ask a question, you're literally in your mind kind of thinking of how to rephrase it to make it open-ended. The second, the A in ORS, is affirmations. So using actual statements or even just your body language and gestures to acknowledge the person's strengths and the behaviors that they've, even if it's just a small amount, that they're showing in a positive direction for change. And it's really important as a healthcare professional to just recognize how powerful this can be. A lot of our patients who have different behaviors that are affecting their life, they're affecting others in their life as well. And they're hearing it from everyone. All they hear is negative and nagging. And so it can be really powerful as the healthcare professional to not be the one doing that, to look for the positive, even if, again, it may be just a little bit of positive, but looking for something positive in what they're doing. It can really just help build your rapport with them. But it really can, if they look up to you, it really can help them develop confidence and all of those things. So just to remember how important that is to use these affirmations, as somebody's healthcare professional. Just some examples of affirmations. Sounds like you haven't been able to stop drinking, but it's good you've been able to cut down. I appreciate you being open with me about your drug use today. You handled yourself really well in that situation. So again, the person may be continuing to do the behavior, but even small, somebody who, again, because we've been so focused on total abstinence for decades in the US on how we look at addiction treatment, and somebody who just cuts down on their use. Again, it'd be nice if they weren't using, but that is a positive thing that you want to, affirm with them. Somebody who stops injecting and is only now sniffing drugs or smoking, again, still potentially dangerous, still might be harmful, but definitely less harms than they could have had continued to inject. The third letter in the ORS is reflective listening. So you're doing this for a few reasons. Part of it, you're just demonstrating to the patient that you're listening to them and trying to understand what they're saying. Allows the patient, if somehow you've kind of overstepped or you're thinking down the wrong road, it allows the patient to clarify if you kind of repeat back and you've misunderstood something. There's a lot, I mean, we could talk about this for a long time, but there are a lot of different ways to reflect. These are just some of the real basic, literally repeating what the patient said. You can rephrase things using synonyms, but staying close to what they say. The third one is kind of when you reflect, but you also introduce thoughts and feelings that might be related to what the person is telling you. They may not have actually said, so you're kind of adding in a little bit of your own spin on it. So, I know my drinking can get out of hand sometimes, but it's what we all do. All my friends drink like that. If I stop drinking, I don't know who I go out with or what I do for fun. I'm worried about what would happen to my social life. So you can focus on different aspects of that. So you feel like you'd lose all your friends if you had to change your drinking. Sounds like drinking is a big part of your social life. Drinking seems to be getting out of hand sometimes, but you're not sure what would happen if you tried to change it. The idea of changing really scares you. So you can see, they're all kind of saying similar things, but the last one here is talking about really the affective, um, emotional um, aspect of what the patient is feeling. Some of it's talking more about the kind of the logistics of the behavior and hanging out with friends. So some of it, as you do motivational interviewing, you start to pick up on what's more or less important for a given patient. And then you use these reflections to kind of bring in things, even though again, you're basing it on what they've just told you, but you're then able to introduce and kind of have things go a little bit in the direction that you feel is appropriate. Then the last one there is the summarizing. So it's very similar to reflective listening, but you're doing it kind of as you're trying to wrap up. And again, it can be used to help kind of terminate one phase of the interaction and steer it in another direction. So just ways to bring up and again summarize. Again, a lot of this is what lots of clinicians now are just learning how to talk to patients, period. All right. So I mentioned big focus of the third edition of the motivational interviewing book is on change talk. So Miller and Rolnick kind of talk about this as being the opposite of resistance. So it's listening as the patient talks for, kind of self-motivational statements, things that kind of talk about the disadvantages of continuing what you're doing, the advantages of changing, any kind of hint of any intention to change, or even being optimistic about maybe being able to change. There's another mnemonic you hear for change talks. I don't know who came up with this darn cat, but so the desire, the preference for change, the ability, like we've talked about before, that the person feeling that they're capable of making the change, reasons for wanting to change, the need. So sometimes a person feels like an obligation kind of being imposed on them, might be a real imposition by, say, CPS or, the law, but, it might be just a kind of perceived obligation, a commitment to actually an intention to make a change, actuation, where the person, if you're thinking of the stages of change where they're now ready to do it. And then finally taking steps where the person's talking about things that they've actually done. So again, another mnemonic that again kind of overlaps with some of the others, but just the different types of statements that you're listening to for the person to make that they're either thinking about or ready to make a change. Different things you can do to evoke the change talk. So, asking, evocative questions like, if you were to try this, what do you think would happen? We'll talk about some of these other things, the importance ruler, the decisional balance, just elaborating. So again, just using more open-ended questions to have the patient continue to talk more about whatever the behavior that they're talking about is, or the consequences of it. Querying extremes, so just kind of saying, well, if you can imagine, now you're drinking this much. If you can imagine, you get to a point in your life where drinking more than that, what might happen? Um, Imagining, some other consequence that your husband leaves you, what do you what do you see happening then? So kind of looking at extremes of the behavior sometimes will help people think about it differently. Both looking back and looking forward, just having the patient kind of talk more about their life, before a behavior or before the consequences of a behavior started. Sometimes that can help. And the big one is just asking them to explore goals and values. A lot of times that can help stimulate them to think about other ways to make a change. A lot of people have heard of the readiness ruler. So that's, asking somebody on a scale of 0 to 10, or a lot of places actually have, either on a piece of paper or now might be on like an iPad as you're checking into a clinic. You might have you think about behaviors. So, and remember, it's not just are you ready to change? So you want to, you know, talk about the importance. How much does the person think this is important for them? How ready or interested are they? Because they might decide, well, yeah, that might be important for me, but I'm not ready to really do anything yet. And then always remembering that third, the confidence. So again, a lot of patients deep down, they know the behavior is something that they need to change, but especially if it's something that they've struggled with changing in the past, a lot of times they just need help with how to do it and developing that confidence. You can, then when the person has done that, you can, say when writing is for change, they say 4. So then you can use those numbers and ask them, well, what do you think it would take for you to make see that as a 5 or a 6? Or, it might be, I would have thought you would have actually said that lower. What made that a 4 for you? So you can use these numbers to kind of help engage them in a little bit of discussion around, again, whether the importance, the readiness, or the confidence. Some people also think of a decisional balance, and I've actually seen therapists that get like like a little balance like this and have, on the one side the positives of a behavior and one side the negatives, and kind of have the patient physically put the positives and negatives. Some people that, tactile, um, doing something can help. A lot of times it's just helpful to ask the patient, and it's important to not just say the pros and cons of a behavior, but you want to look at the good things about it, the not so things about it, but also the good things about changing and not so good about things about changing. Because it really, even though they seem like they would just be the inverse, for a lot of times when you're asking somebody, the differences can really make them think about it in a different way. So again, as you're doing this, you want to avoid the yes, no questions. You want to really have them talk about more kind of what they're thinking. Some people, it can be really powerful to have them write it out. So using the decisional balance sheet. So again, making sure you have the pros and cons of the behavior, the pros and cons of changing the behavior. Again, they've often been hearing just from everyone all the bad things, that it's like, like I was saying about the affirmation, that it can be really powerful for the healthcare provider to focus on the pros of this destructive behavior, recognizing that, when people start usually a behavior that becomes destructive, when they start out doing it, it's not destructive. There's often good things about it. So recognizing that and being able to talk with them about that can really be, again, a powerful thing, and something that might not be happening in the rest of their life outside. So, again, a lot of times just seeing things listed out can help. The person can talk about it and not, it doesn't really register, but when they see it listed out, that can really matter. The other thing, though, is that's important is remembering that not everything in the list is equal. So, there might be a lot more cons here, but, you know, feeling more accepted might be much more powerful than all these cons together. So again, it's a helpful thing to do with the patient, but also just remembering that just the actual numbers don't necessarily mean anything, that things have different valence, and um, the more important things, again, like a lot of people here probably worked with, like around intimate partner violence, there's going to be tons of cons for staying in a relationship, but the one pro is what's helping that person stay in that abusive relationship. So again, this can be very helpful, but don't necessarily think of it as just simplistically pro con. All right. So I mentioned, just some resources. So over here on the left, that's the third edition of the Miller and Rolnick Motivational Interviewing. And like I said, I really recommend people that want to learn more about this. It's a really easy read, very thought-provoking. They have a lot of clinical examples in it. So it's a really good book, I think, to get if you do this kind of work. There's lots of, if you go on YouTube and all, there are a lot of videos. Bill Miller, especially, both of actually Miller and Rolnick, they go all over the country and do trainings. So look for that. If you really want to get into it, there's actually over here on the right, it's called the Motivational Interviewing Network of Trainers, or MINT. And so what they do is actually, provide intensive training. So you actually have to record sessions and send them in to a supervisor who reviews them, goes over them with you. So you actually, like, get sort of like a certification in motivational interviewing, which is, again, it's something that a lot of people really find useful, but most clinicians aren't going to go that route of getting minted. But it is helpful to, because a lot of people, when you ask them, they're like, well, I already do that. And there have been studies where people thought they were doing motivational interviewing, but then when they had, professionals kind of record it or watch them, some of the things they were doing were in the spirit of motivational interviewing, but some of it wasn't. And the reality is that doesn't mean that you're not helping people. And a lot of times, depending on what your specialty is, so a lot of times, as a physician, say I'm seeing somebody in an emergency room, there are a lot of times there are time pressures that everything can't be an open-ended question, that you have to get some answers. I have to know if this patient's suicidal. I can't just say, talk in an open-ended way around that. So it's important to keep that in mind. It's also important, to remember, if you are an NP, a PA, or a physician, you can prescribe. We talk about this being collaborative and kind of the clinician and the patient are equal, but you have to remember, when you're prescribing for someone, you're the one that can prescribe to them. And so if it's something around pain medicines or a benzodiazepine for anxiety, that the idea of motivational interviewing, it that the fact that can't be purely collaborative, and obviously you do it as collaboratively as you can, but the reality is the prescriber has something that the patient doesn't. And so that's another aspect of motivational interviewing for prescribers that makes it a little bit different than kind of the way it's spelled out there. So. All right. Oh, okay. And this is what Bridget already mentioned. Just I'll leave this up there for now. But yeah, if we have questions questions? I don't know.
Yeah, kind of connected to the last slide. Someone asked me, do you have to pay for Mint certification?
Yeah, I don't know the details of how much, but yeah, it's not free. And because again, they're Mint, motivational interviewing kind of very, very seasoned people that are reviewing your cases and all. But I think there are also more institutions that are kind of trying to do some of this, and certainly like in medical schools, a lot of medical schools are trying to, again, they're not getting fully Mint certified, but really trying to at least observe clinicians and give them feedback. I mean, even doing that a few sessions can be really helpful, not the many, many hours that to be Mint certified requires.
Okay, thank you. Thank you so much for your whole presentation, Dr. Welsh. Please enter your questions into the chat and we'll relay them here. One question that I did see was, what was the catalyst to move the field from an abstinence-based model to this harm reduction approach? Was it solely the opioid epidemic?
Well, I mean, this could be a many hours discussion, but um, certainly things were moving. We had movement in that way in the United States even prior to kind of the big prescription opioid epidemic, but certainly most of the movement in the last decade, 10, 15 years, has been a result of that. And just, prior to, the late 90s when the prescription opioid epidemic really hit kind of everywhere in the country, a lot of the prior heroin epidemic was really, centered in the big cities like, Baltimore was one of the main ones, but it was largely, and again, it wasn't ignored. I mean, people were doing things about it, but it certainly took on a whole nother level when it started hitting rural and suburban areas. And then in, the late 2000s, when we really tried to address the overprescribing of prescription opioids, and then all these rural suburban areas that had had the big Oxycontin problems, all the Mexican heroin cartels kind of flooded them. And so certainly it does seem to have had a lot to do with this, the opioid epidemic, and just hitting different areas and different people being affected that didn't care so much when it was mostly the inner city poor that were being affected. There's a lot more to it, but I do think that that is much of it. But I think it's also just, just many other countries have had much more of this kind of attitude for much longer. So I think it's just seeing what was happening in other areas. Um, Certainly, and even with alcohol, when the medicines we use for alcohol use disorder, they've never really caught on, and partly because they're some of them have higher rates of total abstinence, but they seem to help most people just drink less and drink in less high risk ways. And for a long time here in the US, we thought, well, that isn't really treatment if the person's still drinking. And so I think, even that we're kind of relooking at. So yeah, I think the opioid epidemic really, really has pushed it and sped it up. But we were certainly looking at things a little bit differently before. And I think part of it is just, the research wasn't necessarily supporting that the old ways of doing things were ultimately leading to the best outcomes.
Thank you. Next question I'm seeing is working in child welfare and trying to partner and motivate customers that are not always considered voluntary. Do you have any pearls of wisdom of where to start to build motivation?
Yeah, well, I mean, I think, like I said, a lot of people, the external factors really do help, push them to want to change. So, I think it's a reality, so you have to recognize that it's there. Um, but I think again, it's also trying to look at things as not so black and white, not so using or not using. The implication that somebody, just because they're using a substance, can't be a good mother. Um, you know, there are some people who are using and they are good parents. So it's hard, and it's hard for an agency like CPS to not kind of be black and white. But I think in the end that you're helping more people if you can be more nuanced and do that. But again, ultimately the change has to come from within, and the person has to want to do it themselves.
Thank you. The next question I'm seeing is, do you have any specific tips or ideas about working with pregnant women who are using alcohol?
Well, again, that could be a whole many hours in and of itself. But again, I think what all of motivational interviewing is trying to find out what's important to the person. And then, but also some of it's just education. Some really, you think everyone's heard of fetal alcohol, but some of it might be literally just education. But it's really finding out what's important to them. Um, you know, being the safety of the baby, um, whatever, but finding out what it is, if they're resistant to stopping drinking, trying to find out what those pros are, what for them is making it harder for them. And that's going to vary from person to person, whether it's the socialization, maybe there's underlying depression that they're kind of self-medicating. So a lot of it is really working with them to try and find out, again, looking at that decisional balance and what are the pros of continuing to drink with them, and then trying to work on um, how to kind of shift that to the where they notice that it's a problem and need to make a change.
That is all the questions for now. We can keep it open for about 3 more minutes. Please enter any other questions you have. But other than that, thank you everyone for being online today. You will be able to log into the Max Oasis portal. I'll send out a link to that once again if you are not sure if you have access or don't have the link on hand. I can send that out again this afternoon. But in that portal, you will be able to access the slides, the evaluation survey, and then once the evaluation survey is filled out, you will be able to access your certificate there as well. We are seeing a bunch of gratitude and thank yous in the chat. Thank you all for staying online this entire time. If you have additional questions for Dr. Welsh after today on any topic, please call our warm line or email us and we're happy to connect you. But feel free to log off if you do not have any questions. And thank you again, Dr. Welsh.
Yeah, thank you. And again, like Bridget said, take advantage of Max for Moms. We're always want to answer clinical questions, but also a lot of practices, especially if you don't do primarily addiction work, just don't know how to kind of add that into their practice, and that's something that we can help with.